everybody, and welcome back. I'm often asked to give lectures on different echocardiography cases that are encountered in the hospital to people with different levels of experience. And I reviewed my case stack and I found some very good cases that cover basic things that you'll see in the hospital setting, from cardiological emergencies to regular pathology. So this is part one of a part two series, and I hope you enjoy it.
Okay, on our first case, we see this collection of fluid which appears to be outside the heart. Now, the question is it in the pleural space or pericardial space? Well, here, the main landmark is our aorta here. And anything that is between the left ventricle and aorta is pericardial in nature, whereas anything that is outside of the aorta here is pleural in nature. So sometimes it's very difficult to differentiate the difference between pleural and pericardial, especially in other views. But this parasternal long axis view is key because you can see a separation between the left ventricle and the aorta. So there is a considerable amount of pericardial effusion. And on the short axis view, we can see the pericardial fluid is surrounding the left ventricle. And this person was hypotensive and in tamponade. Things that we also look for are flow variation of the mitral and tricuspid inflow, and this is respiratory variation of the inflow. The percentage of variation is anywhere that is thought to be significant for tamponade physiology is about a third variation. Pericardial effusion is commonly seen inside the hospital setting, especially when you have a post-operative program. You could also see it in the community secondary to viral syndromes. And if it accumulates quickly, it can result in tamponade. You want to look for RA-RV compression because there's a lowest pressure systems. And as the intra-pericardial pressure increases, you have decreased venous return and you have IVC dilation. You can also have, as we said, respiratory variation of the mitral inflow and also pulsus paradoxica. So when you have respiratory variation, typically your blood pressure peripherally or on the A-line varies with respiration. Now, pulsus paradoxicus can also be seen in other scenarios. It's not just seen in tamponade. It can include constrictive pericarditis, COPD, anybody that's intubated, a pulmonary embolus, or dyspnea. And now, no pulsus paradoxicus can be seen with tamponade in somebody that has atrial septal defect, aortic insufficiency, very high LV filling pressures from a stiff ventricle, and also positive pressure ventilation. This is another case where the patient was hypotensive, and the question is there anything compressing any chamber of the heart? You don't necessarily have circumferential pericardial effusions, especially postoperatively. And here, the troublesome thing here is you see flow acceleration across the tricuspid inflow. And that gives you a clue as to there may be something outside compressing the heart. Here we have some variation, as you can see, of the tricuspid inflow. And there is RA compression, as evidenced by the flow acceleration. You have another case here where somebody is hypotensive, and the question is, what's going on? So is this the left atrium, left ventricle, right atrium, right ventricle? We don't see the tricuspid valve well here, so we're going to have to take more views. Here again on the tricuspid, we do not see tricuspid inflow well, and we need more views. Now in this view, this is where the right ventricle should be, and we really just see the space with this fibrinous material. So it turns out that this turbulent inflow that we saw in this previous view here is compressed from the right atrium and right ventricle from a pericardial effusion. So in essence, all that we saw in the previous slide here is pericardial fluid and does not represent the right atrium. And you can see a hint of the right atrial wall being compressed here in retrospect. So this is all pericardial fluid collapse in the right ventricles, which is pretty dramatic. And this person was drained emergently and did well. Here we could see a subcostal view where here you're supposed to see the right ventricle. And here you don't see the right ventricle and you don't see the right atrium. Initially, it's a very confusing view, but the right ventricle is plastered on the septal wall because of the external compression. So pericardial effusions do not have to be circumferential, especially post-operatively. And it's very important to be able to notice these loculated, localized variations. Okay, our next case here, we see that we have some kind of right ventricular hypocontractility. And here we have some flattening of the interventricular septum in somebody that is short of breath. Further imaging allows us to see a dilated right ventricle with right ventricular hypocontractility, however, preserved RV apical function. This pattern in somebody that is acutely short of breath with a dilated right ventricle that is hypokinetic in the base to mid body and has preserved function in the right ventricular apex is very suspicious and pathognomonic for pulmonary embolism. And that's exactly what this person had. It's a very common disorder, especially in hospitalized patients, that can be underdiagnosed. And we can often have echocardiographic clues as to its presence. Sometimes we see stress echoes that are referred to us in somebody with chest pain and shortness of breath that actually are pulmonary emboli that have been missed, and we can pick this up by this very important right-sided features with preservation of right ventricular apical function. Next case here, we see something. This is a patient that is having persistent chest pain in the ICU. It is not making any enzymes, but is having persistent chest pain. We see here, this may look like an effusion or pericardial fat. It's hard to tell from just that view. It may just be pericardial fat. But we see here something that looks like the aortic valve and something that's above the aortic valve. Something just not right here in somebody with persistent chest pain. Short axis view, we see something here that does not look like a valve. and our suspicion should be an aortic dissection. In fact, you can pick up half of the aortic dissections simply on transthoracic echo. Furthermore, on our 4-chamber view, this is left atrium, left ventricle, and this is our aortic outflow. We can see that there is significant aortic insufficiency. So the suspicion is aortic dissection. As you know, this could be life-threatening because the dissection can go forward and enter the pericardial space and cause tamponade. Any proximal aortic dissection is a medical emergency. This is a transesophageal echo that was used to confirm the diagnosis, and you can see the dissected membrane. Furthermore, you can see true lumen here and a false lumen here that eventually gets clotted off. And this person was taken to the OR and did well subsequently. Okay, our next case is somebody that has had a myocardial infarction. So we could test your knowledge a little bit about the pleural versus pericardial effusion here. And we have this echo-lucent area outside the heart. And how do we know if it's pleural or pericardial? Well, it's outside the aorta, so that has to be a pleural effusion. If it was in between the left ventricle and aorta, pushing the aorta outward, that would be different than this would be. This really trace amount is your pericardial fluid. We see something, big area of hypoakinesis and something that is bulging out here. And we see this on the anterior wall, and we see it all the way in the apex. So this is a large neural thrombus post-myocardial infarction. Very important to pick up because of the risk of embolization. Sometimes, and a lot of times, these thrombi are not obvious on transthoracic echo imaging without the use of Definity. So especially if the LV apex is not well visualized or it's aneurysmal and there is artifact in the LV apex, echo contrast should be used to find thrombi. Even small thrombi are very significant because of the risk of embolization and stroke.
I hope you all found this both enjoyable and informative. If so, please subscribe to our channel and get ready for part 2 of case studies.